Welcome, Dr. Richard Carvajal. How are you?
I'm good. I'm good. How are
Well,
you?
thank you very much for joining us for this Beating Melanoma project. And we have a special guest tonight. And Dr. Carvajal is actually the director of a melanoma service program and as well as a director of the experimental therapeutic program at Columbia University Medical Center in New York City. And we sort of known each other for almost 20 years. We took care of some patients together at Sloan Kettering. And Dr. Carvajal is very accomplished, has published more than 150 papers and book chapters and books on treatment of melanomas. He has received numerous accolades and awards and grants from the FDA, from the National Cancer Center Melanoma Research Foundation, et cetera. And he's been instrumental in doing a lot of those clinical trials for melanoma on the eyes, foot, as well as the mucosal area. So it's a great honor to have you. Welcome, Richard.
Thank you so much for that very kind introduction.
So, you are a medical oncologist and also you are a clinical trial physician who does clinical trials. And in your mind, what do you think are the major breakthroughs in treatment of melanomas in the last 10 years?
Oh, Stephen, it's been such a remarkable field, as you know. I mean, from the medical oncology stance, talking about systemic therapies, the advent certainly of targeted therapies that were effective were certainly an enormous deal. But really what's transformed the field has been the development of these, checkpoint inhibitors, that kind of this new class of immunotherapies that have led to clinical benefit and cancer cures in about 50% of the patients that we treat who have widely metastatic melanoma. I mean, it's really remarkable, right? That we can just, take these drugs, these anti-PD-1 antibodies, CTLA-4, do them in combination, teach the immune system to recognize the cancer and then completely eradicate it in a, not everybody, but a very significant proportion of patients. It's absolutely remarkable.
Yeah, I remember the first time I wrote this Beating Melanoma book, that was like 10, 15 years ago. And by the time I published it, there was nothing, absolutely nothing, right, for stage 4 disease, stage 3 disease. Let's just walk through it. And for the patients, who don't really have access to someone like you, the expert, what is that process? Let's say someone come in, your surgical oncologist, your surgeon, or your dermatologist refer the patient to you. They say, okay, now the patient has, let's say, stage 4 melanomas, right? That's someone who have melanoma spread to the lung, the liver, and they come to your office. What is that consultation process like? What do you tell them?
Yeah, so there are a few very, very important things. I think, I'd love all people dealing with melanoma to know. One is that the management has to be what we call multidisciplinary, right?
Yeah, totally.
It can't just be one doctor taking care of everything. It has to be a team that includes medical oncology, surgical oncology, radiation oncology, dermatology. And in fact, as you know, at some of the larger centers, we have routinely these big disease management team meetings where there's a room full of specialists with pathologists, dermatopathologists, and radiologists just looking at the case together to try to come up with the right plan. So I think, that's one key factor, kind of understanding who your team is.
Totally agree.
I think the second piece is that, the treatment of cancer is becoming increasingly personalized, right? That's true for melanoma, that's true for all cancers. And it's very important to really understand what subtype of disease you're dealing with. So for melanoma, we'll divide it into different subtypes, but one of the key things is kind of what are the molecular drivers of that melanoma. And so we'll want to understand, you'll hear these terms like, is your tumor BRAF mutated or NRAS mutated? Does it have PD-L1 expression, LAG3 expression, maybe?
Exactly.
Yeah, and so there are all these different factors that it's going to be hard to understand, but basically you want to make sure that we understand as much as possible from the tumor that was resected or biopsied. The third piece I would say is that even in cases where the melanoma has spread, our goal is still cure. And that was not the case 20 years ago. 20 years ago, our goal was to say, let's try to control the cancer for as long as we can while maintaining quality of life. Now the goal is let's eradicate it. Let's get rid of it completely, maintain quality of life, but the goal is to get rid of the melanoma altogether, which has totally changed the way we think about treating disease. 4, and sorry this is going so long, but I hope this is helpful for the group, the audience. We need to know what kind of the standardly available treatments can be used, immunotherapy, targeted therapy. Those are really the two big choices, as well as, and I know we'll get into clinical trials, but you always want to keep in mind what are the newest therapies being tested, and do I want to think about being involved in one of those trials? Because the things that we're studying today will be the standard of care therapies that will hopefully increase that cure rate in 5 years or 10 years. And if we can access that now, maybe we should think about that.
So just to summarize, I mean, so you went through a lot. One is you need to know a team. It's a team approach. We have tumor board, et cetera. You need all the specialists come together to figure out a plan. Second is identifying the specific gene mutation, right? You basically have to analyze the tumor basically and to see what type of mutation you have so you can know what to act on. And third is using the two major driver, it is immunotherapy or targeted therapy. And fourth is thinking about clinical trials. So let's delve down a little bit deeper. And for stage 4 melanoma, let's say, you presented the case, the tumor type, and how do you decide to using a single agent immunotherapy versus a dual agent? Before you had PD-1, CTLA-4, now there's another one like LAG-3, right? So how do you know which one, mono versus dual? What is your thinking process?
Yeah, so that's a really great question. I think the field for the most part has shifted to doing dual checkpoint blockade as kind of default. There are definitely cases where we can do single agent anti-PD-1. Now that it's probably the LAG-3, relatlimab, nivolumab combination. But that combination of ipilimumab and nivolumab, that's the regimen where we have very long-term data, now over 7 years, median follow-up showing that we're curing, a very significant proportion of patients.
I'm going to push you a little bit, just asking you for stage 4 using this dual approach. What is the cure rate for stage 4 at this point?
I'll quote between 40-45%.
Yeah.
Obviously not as high as we need it to be, but it's far better than where we were 10-20 years ago.
Yeah, completely agree. I mean, I think this is a very important point. Like if you're looking at some of the AJCC data, they're having just published recently, just even for the stage 4, they're citing survival is only 24-25%. Obviously, that data, that number is outdated, basically. So sorry to interrupt you. Continue. And you were saying, yeah.
Yeah, so I think, the data again is strongest for that ipi-nivolumab combination. There are definitely people who don't need that very heavy duty immunotherapy regimen that has a significantly high rate of, serious side effects. Right?
Agree. Yeah.
And so if we do some of the, let's say, gentler immunotherapy regimens, there are definitely some cases where we can get the same degree of efficacy, right? Potential cures with a lower rate of bad side effects. The way I would kind of conceptualize it, though, just for the audience, is we have the heavy duty immunotherapy, ipilimumab and nivolumab, kind of the default. We can do anti-PD-1 therapy alone with something like Opdivo or Keytruda by itself. And then now we have Opdualag, which is the combination of this new checkpoint blockade agent, relatlimab, with nivolumab. And that's kind of like the middle option where it works better than single agent. Oh, sorry.
That's all right.
Yeah, it works better than single agent, slightly higher rate of, significant side effects. But I think, yeah, there's some more subtleties there, but I think
yeah, of course. I mean, I think this is why, this conversation we're having is purely for educational purpose only, right? And because you have to look at the patient in front of you, you have to sort of see, just how healthy that patient is, the age. There's so many different variables.
Yeah.
So moving a little bit further from stage 4 to stage 3, we're talking about the adjuvant setting at this point. And I mean, I think maybe you can define for the audience, what does adjuvant treatment mean?
Yeah, no, that's a really good question. You know, the way we think about adjuvant therapy is after resection of the melanoma, is there a treatment we can do afterwards that can decrease the likelihood of the melanoma coming back? And so that sort of therapy, that's adjuvant therapy. In this case, we're talking about medicine. And we know that if we do a year of anti-PD-1 therapy, again with Keytruda, nivolumab, that significantly decreases the risk of relapse. For patients with a BRAF mutant melanoma, we can also do dabrafenib and trametinib targeted therapy for a year, also significantly decreases the risk of relapse. For targeted therapy, for the immunotherapies, the anti-PD-1 therapies, we know it decreases the risk of relapse. We're still waiting to see what does that impact survival, right?
Yeah.
A little bit tricky. Preventing relapse, delaying that, clear benefit, but I really want to see that survival. I want to just get rid of it altogether. And so I think we still have to wait on data to mature for to see those results.
Since you brought up the targeted therapy, maybe we can come back to the stage 4 patient. How do you decide? So your first line, it sounds to me your first line of treatment is immunotherapy, right? And how do you use the targeted therapy for a stage 4 patient? Is there even a room to use those therapy?
Yeah, absolutely. I think there's still a very important role for the 40 to 50% of BRAF mutant melanomas. We know a few things. One, there was a big trial just completed and reported out this year and published this year called the DREAMseq trial that actually looked at that sequencing question, right? Is it better to do immunotherapy first, or is it better to do targeted therapy first? It was very clear that outcomes are going to be better if we do immunotherapy and then switch to targeted therapy later if we need it. Again, I think there are going to be select cases where I think there might be a role for targeted therapy first for various reasons, and then maybe switching to immunotherapy. But in general, immunotherapy and then targeted therapy. And again, for the BRAF mutant melanoma cases, we have that option. It's different for the patients whose tumors don't have a BRAF mutation.
Sure.
They're missing that important kind of treatment option. So that's an issue.
All right. So far we touched upon treatment for stage 4, stage 3. What about stage 2B and 2C in the adjuvant setting? And my question is, what's your opinion on this? Do you routinely put patients on this adjuvant? What's the risk and reward benefit?
Very important question. Okay, so first of all, we have a couple of trials that were presented this year for the patients with stage 2B and 2C. These are no negative, but still relatively high risk melanoma cases.
Sure. Yeah.
And it was shown that with either pembrolizumab or nivolumab for a year, the risk of relapse significantly decreased, right? So it works regardless of the stage. So that we know. But the issue is we know there's a significant risk for toxicity, even with single agent anti-PD-1.
Yeah.
We know that some of those toxicities, many of them are transient, right? Like they happen, we can treat with steroids and then they go away. But about 15 to 20% of these toxicities are what we call these endocrinopathies. These are side effects that affect the hormone glands of the body, the thyroid gland, the pituitary gland. These are like the hormone producing glands of the body. And when those get affected, it almost never comes back. And so these are permanent side effects. And if that happens, patients have to be placed on lifelong hormone replacement therapy, basically, right? So lifelong thyroid, hormone replacement, whatever. so there's, that's an important downside, I think. So if you have a
Very
30-year-old
important downside, yeah.
2B melanoma that very well may be cured by surgery alone, do we treat, right, with the knowledge that will reduce the risk of relapse, right? But we don't have the data that treating now in the adjuvant setting is any better or any worse than waiting to see if, God forbid, it recurs. Let's treat then, still with the goal of cure.
Yeah, yeah.
Right.
I mean, hopefully by then, let's say, if God forbid this recur 5-7 years down the road, you may have some newer therapy that has better clinical efficacies. So you mentioned something very important, 10 to 15%, this issue with endocrine related issues, side effects. Do we still worried about injury to the lung and injury to the colon? And, how is it something that you can reliably predict? Can patient reliably can figure out they having this, or this is some haphazard?
Well, so yeah, so I mean, that's an important question. How can we predict or identify which patients are at higher risk of developing these side effects? Really critical question. A lot of people are like looking at various assays and biomarkers to see if we can do that. In fact, there's some really impressive work that just came out of NYU looking at kind of proteomic analyses, right? And so there may be potential signatures to identify those who are at risk of these, what we call immune-mediated adverse events. But there's nothing that's ready for prime time. And so we're certainly worried about all of those side effects. And I'll say when I treat patients with combination ipilimumab and nivolumab, where the risk of what we call a grade 3 or 4 side effects and bad side effect is over 50%, I'll watch them very closely, sometimes with weekly visits in the beginning, because when we look at prior data, some of these side effects can be fatal, right?
Yeah, yeah.
And somewhere between 0.3, 0.6% of patients who are treated, this is older data, but between 0.3 and 0.6% had a fatal toxicity, right? And they frequently occurred early on. And we know that if we don't catch the side effect early, if we don't kind of act upon it, it becomes harder to treat.
Well, what do you look for? I mean, I think this is a really important point, right? Because, some of the dosing regimen is same basically. And everyone, they can go to some other medical oncologist, but what do you look for? Like, what do you look for in that patient to make sure, what question do you ask basically? And what do you tell your patient basically?
Yeah, so I think this sort of therapy has to be a very, very, very close partnership between the doctor and the nurse and the patient. And basically, I say we need to know if anything is off, and I need to know immediately, not 2 days later, not 4 days later. Colitis is a common side effect, so diarrhea.
Sure.
And I'm not waiting for frank, watery stools 10 times a day. I'm asking patients to let me know if they're feeling bloated, gassy, if they're going, a couple more times a day than normal, even if it's formed. So the patients need to let us know if anything is off.
No, that's really, really important. So coming back, before we jump off to the clinical trial side of it, do you think there are questions a patient should be asking, but they're not? Are there any of those that popping into your mind so you can share it with the public?
Yeah, I think, look, it's very important to make sure, and again, I'm a clinical trialist, so this is, the questions are, what treatment do you recommend that is available as far as standard of care? What is the state-of-the-art treatment with the best outcomes today? Right, and is that what you're recommending for me? And then 2, what are the key clinical trials, right, in that space, whether it's in the adjuvant setting, neoadjuvant setting, and we have to talk about neoadjuvant, or in the metastatic setting, right? What are some of the key and most promising therapies that I might want to consider? And if you want to consider it, is it available, through you or are there other institutions that I should go to for other opinions? I and I will say, so being at an academic center, there was a time when virtually a very high percentage of patients with advanced melanoma would go to big academic centers because they needed those clinical trials. Now we have effective immunotherapies. They can get treated closer to home. Huge benefit.
Huge benefit.
Huge benefit. But what that means is that it's becoming increasingly hard to answer some of these important questions about these new therapies, right?
Yeah, yeah.
And so I think access to trials is really important. I would definitely urge anyone going through this just to be a little bit aware of what
There is the option of clinical trial. So that's really a good segue. Let's talk about clinical trial, right? And this is what you do, and you've done a lot of important work. Who is eligible for clinical trial? And who should be even thinking about it? And maybe walk us through, is it just someone who have failed the standard treatment? Let's say they're stage 4 disease and they tried the combination immunotherapy, it's not working. Those type of patient only, or there are other groups?
Yeah, and so there are important clinical trials going on for every single stage of disease. And so we have clinical trials for people who have melanoma with lymph nodes still in place. And we've got a number of clinical trials to give medicines before surgery, see if that impacts outcomes and what that does to the tumor. And so those are those neoadjuvant clinical trials. So even before surgery, there's some things that you might want to consider. After surgery, we have adjuvant clinical trials where we're trying to improve upon the efficacy that we're seeing with single agent PD-1 or targeted therapy. And then in the metastatic setting, we have many clinical trials, even for patients who have not received kind of the standard of care therapy.
That's interesting, yeah.
And there we're combining, right? We're combining the standard of care immunotherapy and adding something else, or doing the treatment a different way that will maybe decrease the risk of side effects, or combining targeted and immunotherapy. So it's not just when you've exhausted all treatment options. At every single point in disease, and this is true for all cancer, but certainly for melanoma, at every point in disease, if you were inclined and had access to some clinical trials, there's going to be something really promising for you.
What is this? Who's paying for this? Basically, is it the drug company or the patient is paying for it? And maybe you can also talk to us about the logistics. Is it I know, but sometimes you have placebo. It's like the two controlled arms, and how do you even know? I'm getting the drug. Let's say.
Yeah, so these are all really good questions. So first of all, the placebo question comes up a lot. There are a lot of fears I think that people might have about going on a clinical trial, and certainly people will say, look, I don't want to be a lab rat. And I tell people, you are not a lab rat. We are not doing this. We are not doing this just to kind of test without some hope or expectation of potential for clinical benefit. We're doing this to help you. In every single cancer trial, patients are getting, at the very least, the standard of care.
That I think is very, very important, because there's a lot of misconceptions circling around, right, about clinical trial. But keep going.
Yeah. So sometimes we'll give, the standard of care treatment plus a new drug, and some patients will get that, and other patients will get standard of care plus a placebo, right?
Yeah.
The placebo, but they're still getting real treatment.
Yeah.
So we would never deprive somebody of kind of standard of care therapy.
No, that's very important. And here's something else that for someone who's going through the clinical trial, what are some of the barriers, like logistic barriers? Does it require more time, more visit, more blood drawn, more imaging? Or like what are some of the barriers?
Yeah, so the clinical trials, the benefit for people is that they're getting access to something novel, hopefully more effective than what we're otherwise able to give. That's why we're doing this. Certainly advances the science and certainly will help patients in the future, right? So that will happen. Now, what's the cost? The cost is is the logistics. The trials are can be more taxing in terms of travel, time spent in the clinic. A lot of times, especially for kind of the earlier phase clinical trials, where we're studying really new things, there can be like 10-hour days where you're sitting there getting blood drawn, and sometimes you're getting biopsies of the tumor at different time points. And so there are definitely more tests, longer days, maybe more visits, and these typically have to be done at one of the study centers, so it might not be able to be done at kind of the doctor's office around the corner. All of that has to change. All of that has to change. It's too hard. We can't keep on doing trials like this.
Yeah, well, I think we have to bring the trial to the patient, right? Versus for them to come to your center, because you can imagine they're already tired, they're already exhausted. And but so before we stop right here about the clinical trial, how does anyone find the clinical trial? I mean, besides Googling you, right? Let's say, but are there any other places, like, is there a website or?
It's very hard. Okay, so the one source that we'll cite a lot is a website called clinicaltrials.gov.
Yeah.
It's really a clearinghouse of all of the clinical trials. It's a little bit hard to use, so I don't think it's the most user-friendly site, but it is pretty comprehensive. There are fantastic patient advocacy groups like the Melanoma Research Foundation, the Melanoma Research Alliance, AIM at Melanoma. All of these groups have, patient navigators and people who help you access kind of clinical trials and specialists. In addition, I wouldn't forget, I would definitely have a conversation with your oncologist. Right now, I would not expect every single oncologist to know about all of the melanoma trials. It's just impossible. But they might say, look, maybe it's worth a visit to a melanoma specialist. Maybe we can do virtual visits, something just as a one-time visit. So at least you speak to someone who kind of knows the landscape.
Yeah. No, I totally agree. I think we're running out of time, and we can basically sit here and talk for another 2 hours. And we didn't touch upon some of your key work and looking at where you led the clinical trial, looking at targeting the KIT genes and for acral melanoma and the Gleevec trials and a whole bunch of other stuff that you're doing. And I learned a great deal just during the last 30 minutes of conversation, and I think. I would love to have you back sometimes. And by the way, thank you so much.
Thanks a lot. This is a great time. Happy to come back anytime.
Well, happy holidays. Thanks again for your time.
Happy holidays.
Bye-bye.